Hi there, welcome everybody. Richard Hallinan here. In the absence of our chairperson, Paul Hadley, who couldn't make it owing to a double booking, I'm just the warm-up act, and the main act, the main course is sitting in front of us, Andrew Dawson. He's also got a microphone on, which is a special privilege. What I'm proposing to do is a quick whistle-stop tour through the last year or two of what's been happening in our field. I call it Letter from the Southwest Front because as I was preparing this in my mind and on the slides, I felt the urge at sometimes to speak in the voice of Alastair Cook, Letter from America, and at other times the voice of the guy who does Media Watch. Either way, that's probably about the level of this. If there are questions and comments that come up, I think it would be a good idea, because this is just a warm-up, if we can keep that perhaps to the end of this talk. If you've got anything particularly pressing you want to say or ask, then do put your hand up. We'll have to repeat all questions for the people who are with us by the video link. So, what's been happening in the news? This comes up at least once a year when I have to do grand rounds at Liverpool, and we scrape the bottom of the barrel and we think, oh, what did you do last year, the year before? Is there anything new in our field? You get that kind of sinking feeling. Are we going to do alcohol withdrawal again? What are we going to do about opioids? What's there to say about anything that's really new? This year, of course, there was a very easy biomedical thing for us to present at Liverpool Ground Rounds, and that's depo-buprenorphine, but that was our last topic here, though we might just touch on it slightly at the end. This was actually designed because I couldn't quite satisfy myself that depo-buprenorphine was the only bit of news in the last year, so I went looking in medical journals and Dr. Google just to see what had happened, if anything very much. And I discovered that even if we don't think there's much news in our field, we're always in the news. And one of the themes that will come through as a perennial theme in this is tension between harm reduction as approach to alcohol and other drug problems and supply or demand reduction. The tension working out in front of us in several ways, but we'll go straight here if I can make this thing work. Jonathan, I need your help. Slide down, press the show button. What did you do?
Yep, just usually either down button or the left button. So there you go. Yep.
Have to press harder. Well, of course, ice is a big thing. It really is a big thing. I'll speak of ice in inverted commas. In relation particularly to our prisons and our psychiatric wards, I think somewhere between a quarter and a third of the patients at any one time in the psychiatric wards at Liverpool are there with a drug-induced or drug-related psychosis. And the human cost is indeed enormous, and it's really hard to treat. And, you know, many pharmacotherapy has been tried in the past. This protocol, I think, was published early last year. I hope we might have some preliminary results we could present. No, the recruitment's going on. Wouldn't it be wonderful if we have a maintenance pharmacotherapy that we could give to people who are stimulant dependent? The elegant idea of this one is that lisdexamphetamine, like the F there, is a prodrug, and so you can't really accelerate its use by injecting it or ingesting large amounts of it or crushing it up and swallowing it in that way. And it was originally developed, I think, for treatment of ADHD, but they wanted a product that would allay some of the concerns about inappropriate use and diversion, and indeed the idea was this could be a once-a-day medicine. So it looks like it's a nice idea for stimulant maintenance treatment for people with dependence. But if we just take a sober look, as Shane Dark and Michael Farrell have done, likely candidates for maintenance pharmacotherapies for dependence, and you can read it there as well as I can read it out. Psychostimulants appearing poor propositions, because although you might, as you get more and more dependent, develop, as it were, a tolerance and a higher need for these things, the toxicity remains, and many of the toxicities are in fact, there's no tolerance that develops. They're unpredictable and they happen early or late in the natural history of the illness. So the idea of giving psychostimulants to people in the way that we can do with methadone is already possibly fraught. Still, it's good to see it's happening. But in the interim, what do? We do business as usual. I would put you that means that we take our biopsychosocial approach and we attack the dependence from the flank. We deal with the things that we can deal with. We try to make things safer. Of course, we aim at harm reduction where we can. But not necessarily in New South Wales when it comes to festivals, and Andrew will talk about that. Pill testing, no, not in New South Wales. Sniffer dogs, beautiful. Positive predictive value of being indicated at one of these festivals. Sniffer dog, 10%. The standard reported positive predictive value of being indicated by a sniffer dog, where they do it at bus stops and railway stations and the like, those places which are gazetted, as it were, for sniffer dogs to be used, is around 25%. So even in this high risk group, this is not a very good diagnostic test. There again, obviously, that's not the point of it. Medicinal cannabis, it's chugging along. It's been a couple of years now since it's been available. Just trying to look up what's new there. You find far more citations in business publications than in medical journals. That's quite a remarkable thing. That's just, as you see up there, a Google search of a few terms there. And on the right, at the bottom, that's part of the website for Medijuana. So that's being run by a doctor who cares very much and believes in the value of medicinal cannabis, and provides accredited training for GPs, QA CPD accredited online and face-to-face courses at a cost, has produced educational materials and so on, and has partnered with these organisations. Now, these organisations are all about the industry. Entrepreneurs, people who are seeing this as a really big growth industry. They're either producing, investing in companies that produce cannabinoids in Australia, or which intend to market them or deliver them. And they're eyeing off a market that they hope will expand like it has in Canada to be just huge. The people who are investing in this are no different from people who might invest in other startups or indeed pharmaceutical companies. And their approach is to help doctors prescribe these medications, to get them through the regulatory burdens. They do that in one of two ways. They either advise doctors, provide a service where doctors can be helped, and they might even help with the paperwork that goes to the TGA. Or there are clinics which actually have doctors you can consult in person, or more commonly over the telephone, and they'll go through the whole process and prescribe the cannabinoids for you if you meet the criteria. So the names of some of these services: CanDoc with two N's, Medical Cannabis Clinic Australia, CanValate, Medical Cannabis Services Australia, Medijuana I've just mentioned, Medicinal Cannabis Program, and Cannabis Doctors Australia. They're just 8 that I've come up with. Now, I wanted to have this as a topic for today. I think the thing is, this is getting quite confusing for us. It's a bit, but there's some resemblance to the impotence clinics that tried to take over a chunk of a market, the medical need that's in principle quite reasonable. And there are some very well-meaning, and I presume well-informed doctors who have taken on this area. But we have a caution from the old British Journal of Addiction, reflecting this emerging cannabis industry and the conflicts of interest that may arise in publications. Well, it's cannabis for the moment. Here, our public health miracle. So in January 2018, the health minister, federal health minister, said that more than 500,000 Australians had some form of codeine addiction. Well, it's gone. Public health miracle by decree. There is no longer a problem with codeine addiction in this country. There hasn't been much of a shift to Panadine Fort. Codeine overdoses have dropped, as informed by Poisons Information line data published here. Although I wonder, once you take the ibuprofen and the paracetamol out of it, why anybody would call up the poison centre about a codeine overdose. I suspect you wouldn't really. But this great miracle, the miracle is these people have cured themselves. I think because if our experience is anything to go by, there's been no flood of codeine-dependent people that have rushed the addiction medicine doctors. We had a trickle. There was a trickle before. It might have been a slightly bigger trickle for a couple of months. So I don't know where the 500,000 have gone, but they haven't come to us. So that is really wonderful. Less wonderful. The opioid epidemic, as it's called in the USA, and we all know that pendulum has swung away now from the wholesale prescription of opioids for chronic non-cancer pain, and Purdue's gone bust. They've sought refuge in bankruptcy. After, I think they tried to diversify into providing buprenorphine treatment. Some eyebrows were raised by that. We're calling it epidemic. Well, the CDC in America is an epidemiological organisation, and they've treated it, investigated it as an epidemic, and made some recommendations about avoiding opioids for chronic non-cancer pain, of course, all the usual kind of recommendations. But one that's stuck up there right in the middle, which has been very largely overlooked, is they suggesting that if you need opioids for chronic non-cancer pain, you should prefer short-acting, immediate release opioids. But that's quite a big change in the way you might look at this, that the change from the idea of 24-hour round-the-clock opioid cover, preventing so-called breakthrough, and this idea that you might treat incident pain and use opioids more discriminately during the course of the day to modulate a person's quality of life and the capacity to do things. I'll come back to that in just a moment. But not only Purdue was in trouble, Reckitt Benckiser and Divior have been sponsors of this event, and obviously made a big difference to addiction treatment in this country. They saw things coming. They've set aside the $1.4 billion to pay off the fines for the offences that federal prosecutors charged them with. This was, in America, not only unconscionable, but deemed to be illegal marketing. But there has been backwash here for us. Unlike codeine, I think there's been very little. We see headlines like these, perhaps a little bit sensational, but GPs feeling the pressure now to cut back their prescription of opioids, even where some evidence says that only half of them are really actually comfortable with just reducing them. But at least here we have a harm reduction initiative, which is timely and appropriate. So you're probably all involved with the rollout of the opioid overdose response and take-home naloxone project. Good, one up for harm reduction. This patient is Job. He had a night in emergency for a flare-up of his chronic widespread body pain. This is the nature of his fibromyalgia, that sometimes it flares, and if you can catch it with some appropriate opioids, he can abort the flare, but otherwise he'll be sick and desperately sick and will end up in the emergency department. And he's been a nuisance from the hospital's point of view in the last 18 months. Pain Clinic had him on not only a deprescribing opioid schedule for 18 months, but in one letter it was said that he was on an opioid deprescribing policy. Words matter. Opioid deprescribing. Just roll that around in your mouth. I wonder what Noam Chomsky would have to say about that. It's as delicious as the American people on opioid deprescribing. Well, he needs a drug and alcohol referral, obviously, because the deprescribing is not working. He's ending up in hospital. Actually, another pain specialist put him back on Ficeptin and put the dose up. This is no good. As you see, the Australian College of Anaesthetists is recommending that in many cases, it's desirable to wean off the opioids, and you can do this by reducing by 10 to 25% the starting dose each month. For us in our field, that would make most of us a bit breathless. So it's not surprising that some people might find that a bit difficult. But in the case of this gentleman, he needed a drug and alcohol referral. Why? Well, we phoned the GP, no aberrant behaviours, or as some people call them, abhorrent behaviours. No early presentation for prescription. There was nothing to see there. He had actually reduced his doses. It was just these flares that were not being treated. Said eventually to me, I've given him a script for endo. The pain clinic will probably have my guts for garters. But the deal was, I give you a supply of endone for you to use for your flares, and the way that our outcome measure will be you will cease presenting to the emergency department. That was 7 weeks ago, no more presentations. Right, illustration of one idea, benzodiazepines. We're talking about rescheduling, upscheduling. We know, I think most of us, just anecdotally, street prices have risen, even for diazepam. The market is clearly moving to clonazepam and also to pregabalin. They haven't discovered lorazepam yet, probably because it's not on the PBS, but it's only a matter of time. And I think we're all aware that the witch is well and truly being swapped for the bitch here. This is a hydra. Wherever you press down, so Alex will remember the College of Physicians prescription opioid policy, where right at the beginning the conception of overlapping markets and shifting demand was put front and foremost. Have we learned any lessons there? We still don't have real-time monitoring of prescriptions, or so the writing of prescriptions or the dispensing of medications in this country. Though a little glimmer of hope is that through My Health Record, don't tell the patients. If they haven't opted out, you may be able to see their history of prescriptions. So we caught 1 or 2 people out that way. Mum's the word. Another bit of good news. Remember docs became fax, and now they're the Department of Communities and Justice. As you can see here, so jails, the child protection, child removal included, and housing. Yeah, all in one ministry, in one department, as with perhaps a bit sadly written here. It's like cradle to grave for some of our patients. You know, take them away from their children, the new stolen generations, perhaps, as marked here, take the children away from their parents, pop them in jail once they start being in infraction, and when they get homeless, maybe you can find them housing or temporary accommodation, all in one-stop shop. I think that's marvellous. E-cigarettes. So here's a statement from chief medical officers around states and territories and federally, and they all rushed to condemn the use of e-cigarettes after the scare in the United States of America. The connection clearly between the use of e-cigarettes and lung disease. And they specified, the chief medical officer, among some good advice, ask people when they're using these. If they come in short of breath, the emergency department should be part of the question. Don't encourage people to take up vaping. Nobody should encourage that unless. But they cited the precautionary principle here, that is, because we don't know the harms, we will do nothing. We won't allow it. Precautionary principle number 1, this is from an EU document, the principles which should underlie the precautionary principle are those 3 which you see, which you can read there. Include the second point, a risk evaluation and an evaluation of the potential consequences of inaction. So if you don't allow, for instance, nicotine e-cigarettes, because you're not quite sure, it might do somebody some harm, let's watch and wait. And they continue to smoke tobacco for the next 5 or 10 years. If you're really applying a precautionary principle, you should weigh that up. I think everybody's realised now that the culprit for the severe lung disease in the United States is vitamin E acetate in oil-based cannabis delivering products that were not actually manufactured with good manufacturing practice. They were produced in all sorts of ways. But coming now to almost the end of this, the outbreak of what we were calling QT fever in the psychiatric wards at Liverpool, and there was a great flurry of such cases. The index case was a first presentation psychosis in a 50-year-old man, we call him Bart, and he was treated under the Mental Health Act. In the wards, he was on methadone maintenance treatment with a very experienced doctor treating him. He'd been stable by all accounts for the last 10 years. And he was started on aripiprazole, and somebody had the bright idea of doing an ECG. And prolongation of the QTC was noted. It was ceased. A cardiology consult was requested. The registrar came by and noted that the QT had normalised after the cessation of aripiprazole on the next ECG. Therefore, the QT prolongation was iatrogenic and they need have no further involvement. This was a very long hospitalisation. It was very difficult to stabilise this guy's paranoid psychosis. It was deemed, if they couldn't use aripiprazole, that clozapine might be needed. And so we were strongly pressured to reduce his methadone dose to allow the use of clozapine. A guy sitting in the hospital there a very long time. And it was indicated to us that they could actually compel him to change from methadone to whatever we deemed under the Mental Health Act. And so we were asked about the feasibility of this. My view was that it was against his wishes. I had grave doubts about it, but we could offer him a transfer to morphine in the form of MS-Contin. So we did, but to do this, we needed to have some proper evaluation of the impact on the QT interval. So we did quite a lot of ECGs, day by day, morning and afternoon, and we found that with the reduction of the methadone and substitution with the morphine, at first the QT interval appeared to get longer and longer, and finally it went back to where it was in the first place. Around this time, they're still iffing about whether they're going to start the clozapine for him. He was given gate leave, day leave, and he used, as he said he would, methadone. He said, I'm not going to have this morphine, I'm going to go out there and I'm going to have methadone, that's what I want. And there was methamphetamine in his urine test. So the next note indicated that if he continued to use any unsanctioned drugs on leave, then he would be discharged. We were astonished by this notion that you can compulsorily treat a person under the Mental Health Act, but if they don't do what they're told, they're fine to go home. This is one of the early ECGs. So the heart rate is slow, 53. The QT measured by the machine, 571. The QT corrected, 537. Andrew, would you like to comment on this ECG?
Well, the first thing is we don't use QTC either to drug contents. We use the QT. So QTC for the. Oh, turn this off. So this is a really interesting kind of case where people, I think, probably getting themselves a bit muddled. So for those of you who aren't aware, so QTC is a correction of the QT interval for cardiac rate. And it's done with a mathematical formula, and it becomes quite inaccurate if the cardiac rates, once it becomes less than 60, and certainly once the pulse rate becomes over 100. So that's one of the first issues, that QTC by itself can muck things up. The second thing is the ECG machines like to read QT, and the hop back for a second. So let's just find a complex here. Here's a Q wave, this is a T wave, and the idea of the QTC is measuring the distance to whether it gets back to this sort of isoelectric line, this flat line, which is sometimes it's difficult to multiple ECGs. And having done that, you measure multiple ones. So it's just eyeballing this one, because this is kind of cool. This is looking to me to be probably around about 450 or 460 milliseconds, you know, on this lead here. But the way you actually examine this for these ones is you actually have to do between six leads and take the median of them. So that's the first thing. Is the machines themselves quite often get them wrong. If I was doing a talk tomorrow morning to will be doing tomorrow morning. There are situations where if the QT is really, really long, the machines will often miss it. They look for a nice electric line. If it's a really long, they'll sometimes call it there. If the heart rate's very fast, they sometimes they overcall it. They'll go on to the next P wave. So people need to measure it themselves. But the real issue about all of this is that the reason people are concerned about QT is that some people with prolonged QT can get ventricular arrhythmias called torsades. And drug-induced QT is not all equal. So you can have this genetically, okay? And genetically, there are nine variations at least that cause QT prolongation. And so for some drugs that cause QT, it's therapeutic. So amiodarone, if they don't have QT prolongation, they're probably not taking the drug, and it actually probably protects them from arrhythmias. For some drugs, such as amisulpride, if they have an overdose and QT prolongation, 15% of those patients have ventricular arrhythmia. So the point about this is that it's a marker for you to start thinking about things, but it doesn't actually necessarily mean you have risk. And so we see this all the time in methadone patients. If the guy has given a history that he had syncopal episodes or other sorts of things, that would be very important to think about. But if they've not given them that, then you may find that their QT interval gets changes around this time, depending on their cardiac rate, depending on whether their heart rate's going up or going down. And the other things that we normally look at is to make sure they don't have other electrolyte disturbances. So the QT is a measure of the ECG of the cells repolarizing, effectively pumping potassium and calcium across the cell membrane. And so in situations where the calcium's low, magnesium's low, or potassium's low, we'll get QT prolongation. So having QT per se is not an indication necessarily to stop anything. It's an indication to kind of have a look more closely. The ideal thing for this guy is not to do ECGs, but there's actually continuous monitoring and signal averaging. And that's what people would do. That would give you a much better answer. But it sounds like what you're telling me, which is that if QT is going up and down, so it just depends a little bit about when people have taken it.
That was exactly the case, yes. So the phosphanomogram, which Andrew introduced to me, is a way of plotting. This is based on empirical risk of torsade in a quasi-experimental situation. And as it happened with this guy, if you plotted his actual QTs on the nomogram, most of them were above the line for increased risk, if you believed the machine reading of the QT interval. If I just go back to this one, and Andrew, I was taken particularly by these leads B4, 5, and 6, where it appears to me that what might be considered the QT complex here is actually bifid.
Which you can't just, when you've got to, as I said, normally what you do is you have to, if you've not got the fancy expensive machine, you actually have to measure 6 different QT intervals in different leads, and then you find the median one. And the reason why that's useful, for example, if you go to B5, you can't really make any real clear sense out of all of that. So this is, there's a bit of artifact and other things in this sort of ECG. But if you're looking down here, as I said, this is looking here to be about 440 milliseconds. Here, you stretch out, maybe it's coming up to about 460 or 480. But if you go back to the phosphanomogram, you probably would look at that and say, in actual fact, that's just on the line that this guy's pulse rate is, it's 50. So the phosphanomogram, when you say it actually has been quite well validated for risk, and the reason the drug companies use it in the development of any new drug, if you demonstrate QT prolongation, that pretty well kills the drug. That doesn't mean they always pick up all drugs that cause QT, but giving it to a series of animals or normal volunteers, if you get QT prolongation, then that pretty well kills marketing. But that doesn't mean that you may still have some individuals who've got genetic predisposition and may get QT prolongation on some of these drugs not normally seen. And so they've looked at that very carefully, and as I said, it's effectively to get rid of the mathematical error of using QTC correction. So.
Well, thank you for that, Andrew. And so just a final slide here. We eventually got the professor of cardiology involved after about 60 or 70 ECGs. And he said, QT is normal. So how do you know that? He said, I just look at it, if it's a prolonged QT I'm worried about, I know what it looks like. He couldn't, explain it to me. The only thing that we kind of work out was that where a T might proceed into a U, you might have to take the downward trajectory of the T towards the isoelectric line to, if the two are merged. Anyway, if you've got a cardiology professor on board, you might solve the problem. So this guy actually went home eventually on methadone with his psychosis, by the way. He could have stayed on aripiprazole the whole time. The clozapine was never needed. There was no need to transfer him to morphine at all. So stored a teacup, perhaps, and it wasn't the only one. This is Bart's son, Homer. Now you see here, this ECG reported pulse rate of 68, again a QT prolongation, the corrected QT at 587 on those medications. And again, we're seeing this kind of drawn out pattern at the end of the T wave. Well, this one fizzed out too, but before it fizzed out, psychiatry called Drug and Alcohol, who said, look, don't stop his methadone. He's been on for a long, long time. It's keeping you stable. Just watch. And it wasn't quite reassuring enough for psychiatry, called the cardiology registrar, who looked at the ECGs, called the boss. And the instruction was that the patient needed to be transferred to coronary care for telemetry over the next 24 to 48 hours, and to withhold the olanzapine and the methadone. Right. The last paliperidone depot had already been withheld. And they started him on diazepam in case he started getting agitated. And he needed a special because he was psychotic, and he wasn't special for a psychiatric nurse, but rather a security officer. This went on until a more senior cardiology registrar came the next day and sent him back. So I think there's evidence here that some mischief can be done. As I said, we had a whole spate of these. Anybody on methadone was getting an ECG, and anybody who was having any psychiatric medication. I don't know whether it all came from a root cause analysis or something that had gone wrong. And we're still struggling with how to get a sensible dialogue on this in our hospitals. The teams don't necessarily interact that often. Look, I just want to finish up now with a case of buprenorphine and chronic pain. An Aussie veteran on a pension, major physical injuries, PTSD, chronic severe pain, migraines, true migraines, and excellent psychiatric and neurological care. Referred to me by the pain clinic. He was on a long-term ineffective opioid regimen, including high-dose oxycodone and PRN intramuscular morphine. He'd never misbehaved, that was all prescribed, but it was recognised that his quality of life was very poor, socially isolated, low levels of activity, no history of abhorrent behaviours of any kind. So, is this person eligible for methadone or buprenorphine treatment, do you think? So just a show of hands, anybody thinks he is? So we've got a few. Anybody who thinks he isn't? Right, so the is eligibles outnumber the not eligibles. I didn't think he was strictly eligible, but I reckoned we could fudge it. We transferred him to sublingual buprenorphine just to see if we could improve his quality of life. He wasn't an opioid-dependent person under the relevant legislation, but we thought maybe backing off the opioids and rationalising this might just do some good. And I prescribed him Subutex, not Suboxone. I wasn't going to, as it were, insult him with the combination product, which is irrelevant entirely to him. I'm missing a slide. What I can tell you is after that transfer, he reported his pain coming down from 10 plus daily to 4 out of 10. I beg your pardon, just 7 out of 10. And he was almost smiling. For him, this was liberation. He didn't mind the cost. We got him on monthly pickups very quickly. For him, he had a life back. So this already was like too good to be true. We couldn't quite figure out why, but you're thinking, look, maybe there was opioid hyperalgesia, maybe there were other things that were going on. So we tried it. You can't argue with success. Then Buvidal came along, the depot buprenorphine. buprenorphine. And we considered it mainly for reasons of cost, because the pharmacy wouldn't budge, and they were charging him, $45 a week for coming in once every 4 weeks, and the Veterans Affairs didn't pay for it. He was on this state supply of Subutex. We were a bit concerned that if we gave him a depot, he wouldn't be able to modulate his day, modulate his pain management by having his BD Subutex. If it was worse, he could have a bit more. We were unsure about treatment matching here, but we just gave it a go. And here we get this absolute miracle, 2 out of 10, this guy. That's his pain. This is a guy 10 plus out of 10, down to 7. He knows these scores, he uses them all the time, and now we put in 2, and later 2 to 4, depending on what his migraine is doing. So I wanted to finish up by just asking the audience now, is this too good to be true? What could possibly explain it? Andrew, have you got any ideas?
Where's the boss here? Look, we've used this in some similar patients with chronic pain, and I think it's very, very complex. So you mentioned some of the issues like hyperalgesia and those sorts of things. I think there's also a whole lot of issues about illness behaviour and how people perceive themselves and what it means to take lots of tablets and not have control and or pickups and other such things. And so, where to actually use this in a way to actually avoid some of these current behaviours, for example, of picking up and to try and move people on into other things. So, short answer to I don't know. I think there's probably multiple things that could be kind of operating, but these are most of our patients I see, like with chronic pain syndromes, also got a background of very significant life traumas, and there's a lot of stuff kind of going on. They're feeling a lot more complex than just the pain. I'm suspect that this bloke's like this as well. There's a lot more complex stuff going on as well, and they often don't do terribly well with interacting with us frequently, especially if it's not achieving good results. So maybe giving more autonomy.
So thank you for those thoughts, Andrew. Was there a question up the back?
Well, I was just wondering, because it's a demo, right? It's constantly breeding of small amounts of analgesia, and for analgesia for buprenorphine, you're looking at a tight window compared to how long it lasts to satiate you. So because it's actually releasing regular small amounts of the drug, does that potentially offer some advantage?
So I'll just repeat that comment for the people who are not in the room. The suggestion was the depot product might be, with its sustained release, keeping the buprenorphine levels in the body just within the therapeutic window. That might perhaps not work so well with the sublingual daily version. And more or less, that's the conclusion we came to. I did not doubt the fact of his experience for one moment. If you use or misuse the term breakthrough pain, he was probably getting no breakthrough. If you look at the daily kinetics of sublingual buprenorphine, there is quite a fluctuation from peak to trough. So if that's eliminated, and as Andrew says, the psychological aspect, he's no longer even thinking about that, might explain it. But that it was not a result that we expected. It's certainly a result we're excited about. And I've heard that the Camurus company are planning, if not already doing, some studies for the use of depot buprenorphine for chronic pain, for chronic non-cancer pain. So it'll be interesting to see where that heads. Well, that's the end of the news from the Southwest Front. Any questions before we pass over to the maestro for the main course? Right. I'll leave you in the safe hands of Andrew Dawson. Where's your Hawaiian t-shirt, by the way?
Okay, Richard, I didn't know I was the main event. So this has been something that's occupied quite a lot of my time over the last year. I mean, it really is a bit of an intersection of trying to navigate between politicians and public health response. This picture here would appear to be some sort of nightmare that Gladys has had, and then I've reprinted it. driven. What's the behavior? Sorry, I'm just going to turn that phone off. I have it turned on. So what I'm going to do is I want to kind of go through, you know, why we're going to talk about music festivals, because in actual fact, party drugs, you know, every Friday and Saturday night, the festival in Sydney, it's just dislocated and occurring across the city, but it's occurring in a different environment. And in many ways, the environment of both the music festival and the added things that have added into this are probably major players for the reasons why things have gone astray. But in terms of looking at acute toxicity from party drugs, well, this is basically pretty common bread and butter for most emergency departments most of the time. But these are big events and they get a lot of coverage. So I'm going to talk a little bit about, you know, this is A disease, one of the pathogens. So I'm going to talk a little bit about the drug. I'm going to talk a little bit about people and a bit about the environment, because if you want to consider how you're going to try and sort some of these things out, you need to understand the interplay between all of these three factors, and there are things that you can do that dramatically influence the way these factors relate to each other and actually increase the risk of significant toxicity. So these are a bunch of novel psychoactive substances, and just here, this is phenylethylamine, and I put it there because from a tox point of view, all of these drugs here, the amphetamines, amphetamine analogues, N-bombs, cathodones, all of these contain this psychoactive central structure, and depending on which drug you're talking about, literally all of the drugs conspire to increase the amount of dopamine, the amount of serotonin, and the amount of catecholamines in the synapse, either by increasing the release and or blocking the reuptake. And depending on those sort of balances, you get slightly different clinical syndromes. But some of the core areas of toxicity, because I'm a toxicologist, when you push the dose up or you have someone who's very susceptible, look very, very similar. And the other thing about this is when you look at them, they're actually relatively simple molecules, and that's actually quite good, because if you want to, you know, want to be able to get and manufacture drugs, it's best to actually have drugs which are relatively simple and don't require a lot of chemistry, but it does require some chemistry. And so one of the issues in terms of manufacture is that whilst, you know, if you're a bit of an obsessive chemist, you'll probably get it right most of the time. But if you're a little less obsessive, you may actually produce some other substances that are operating in different sorts of ways. So I want to just give two separate kind of case presentations, and I'll kind of come back, because I think these encapsulate, I guess, some of the concerns that people have, and certainly when we were dealing a year or so ago, in particular with the way the media was reporting a lot of these events, I think it tended to make things a lot more confusing. But this is up in the Hunter Valley. It's 2011. This guy took Mdma and Ecstasy pill at 2 o'clock in his truck outside Hexham. It was a reasonably cool day. It basically developed an agitated delirium, and when the ambulance came, they found him severely hypothermic. They restrained him. They had a cardiac arrest. Core temperature 42 degrees. Brought to hospital, had severe acidosis and hyperkalemia. I'll kind of go into the mechanisms of that a little later on. Had prolonged CPR and basically died. But there were some other people involved and who'd also taken the tablets, and they actually survived, but had multi-organ failure and a prolonged intensive care admission, but again with a severe hypothermia. So these are people who picked up ecstasy, and that's what it could have looked like. This is a more recent case, and this is for dance festival. So music festival patron, 4 to 6 MDMA plus some alcohol, found with an altered level of consciousness, called for help at first contact, which would be at one of the medical response tents, very tachycardic, really agitated. by the time he got there, his GCS was deteriorating, his pulse has kind of gone up into 210, it's sinus tachycardia, he's got no blood pressure, and he's got a temperature of 43.3, and that's probably just taken in the year. So just to give you if your temperature starts hitting 41 and you're an egg white, the proteins start to change and alter. So one of the problems when we get really severe hypothermia from any cause, be it from drugs or from malaria or whatever, but temperatures over 41, you start getting disruption of cells and cell breakdown, and things don't work. And so this is really a life-threatening, critical marker of toxicity. So he had some ice packs in the groin, axilla, back then. He's very combative. People are trying to restrain him, to hold him down. This is, a really difficult circumstances. In a tent which may or may not necessarily have adequate resources. So he's handed over to the ambulance. He's got that unrecordable pulse and blood pressure, desaturating. Normally a saturation of oxygen should be above 90%. He's breathing very quickly. He's sedated. They give him some fluids. They try to cool him as they're transferring him to hospital. And during transfer, cardiac arrest, his temperature is still up. He's very, very acidotic. I'm not going to go too much about. I'm going to explain this in a second. He's got this really high potassium. That's generally a marker that all your cells are breaking down and leaking potassium out. He's given a whole lot of measures to try and control his potassium, which is probably one of the things driving the cardiac arrest. Most of these measures here, calcium we use to try and stabilize the cardiac membrane to reduce ventricular arrhythmias. But all the other treatments, bicarb and insulin and dextrose and salbutamol, are all treatments that are designed to push potassium back into normal intact cells. And one of the problems you have if your potassium is really high because your cells are all breaking down, you don't really have a really good destination. So it's actually, whilst we do this, it's actually a lot more problematic than if, for example, Richard just took a whole lot of potassium tablets. We could probably shift them into a cell quite well. And so 1 hour after all of this, the resuscitation events had stopped. So from a toxicological point of view, when you've got a hypothermic, agitated person, from our point of view, actually the treatment's much the same. And I'm not going to go into all the details of that, but syndromically, there are much more aggressive ways that we can decontaminate these people and drop their temperatures, and this is part of the medical response at the moment. But one of the things that you have to be concerned about is, well, are people at different risks for different reasons? And so it turns out this first case, this is I'll drive it a little bit, but this is an amphetamine analog that is not actually ecstasy, which we used to call death. And then a relatively safe drug, as was recently called in the media, is the Mdma. So I've seen this when people report it. So on the one hand, we found, if we tested people, we had 100 people who actually, had ecstasy, and we had 6 or 7 cases of a much worse drug. Well, in actual fact, there's clearly a potential for anything to kind of go wrong in the right circumstances. You've actually got to work out, a bit like the QT, what's the absolute risk of doing this and how can we minimize it? So this is PMMA, so you've still got that phenylethylamine structure there. But one of the problems with this amphetamine analog is that it's euphoric. The onset of the euphoric features that people normally enjoy with ecstasy is actually somewhat slower. And so one of the issues, among other things, is that when we look at death from this, that sometimes people are actually pushing their doses up a little bit faster. It's got some active metabolites, and when it was actually marketed, when people were actually selling it to me, so people were giving it names such as death. You'd think that would not be a seller. So it's got a lot more toxicity because whilst it increases serotonin, it also inhibits monoamine oxidase inhibitors. So for those of you in psychiatry or other things, you'd be aware that one of the ways that we break down catecholamines, such as serotonin, is by monoamine oxidase, an enzyme. And so this is a classic drug interaction. If I gave you an SSRI and an old monoamine oxidase inhibitor, just a single tablet of each, you know, you can pretty well expect that you'll end up in ICU. And we get this all the time through the poisoning centre. So this particular drug's got this extra twist that, you know, would not necessarily be apparent just even looking at the structure. And as a consequence, people, when they push their dose up, or depending on what their underlying receptors are like, or their underlying Mayo faction, or indeed other drugs, have a much higher risk of toxicity. And as I said, they may actually push their dose up because they're not getting euphoria in the same way that they were expecting. So, you know, now, Shulgin, he's got this. So I'm guessing you've read this book, you know. So anyway, this is a sort of a post-60s hippie sort of brilliant chemist who basically worked his way through manufacturing and documenting carefully the effects of a large variety of recreational drugs that he created himself and put all the recipes all down. I think he's published a couple of books in all this sort of sequence, and even he didn't like this. So what I'm going to talk mostly about today is about ecstasy, but I think that we've got to be aware there are potentially other compounds around, but I'm going to talk about this in the context of music festivals. So its predominant effects probably euphorically relate to an increased release of catecholamines and serotonin, but it also does increase some dopamine release, which is kind of important in some of the toxicity. And I'm going to come into the toxicity things as well. So our major concern with this, I mean, after euphoria and things, is whether or not people develop, you know, severe hypothermia, because this has been the mode of all the major toxicity that we've seen in the music festivals in terms of medical toxicity, and that, you know, behavioural issues have not necessarily been such a big driver. So it's interesting to look at the actual risk, because at the moment, as you know, you've all read the media, there's a one pill that can kill, which is, you know, despite us saying, well, yes, whilst that's theoretically possible, that's highly unlikely. But it's about how people perceive risk and what actually goes on. And this is important because this seems to have driven a lot of behaviours, certainly at a political sort of level, that's been, I think, quite difficult for public health people to try and to deal with in that political environment and navigate their way through. So reflecting on the one pill, you don't have to be an epidemiologist, you know, to work all this out. If you've gone to a festival and you figure that maybe 8,000 people have taken ecstasy and one person's died, you know, overall, you know, if you're 18, the risks are pretty good. So this is Professor David Nutt. I think he offended everyone here, but anyway, he looked at this syndrome called Ecstasy syndrome and overall addiction, and basically using established parameters for working at risks of exposure to things about how dangerous things. He looked at ecstasy versus ecstasy, and so you can see the acute harm to person, you estimate, say, 1 per 10,000, you know, people, and whereas ecstasy 1 to 350. Chronic harm, probably more with ecstasy. Intravenous use not applicable. Euphoric effects maybe occurred with both of them. Physical withdrawal, etc., etc. Methane emissions. So what he was actually talking about was equine addiction syndrome, really, where he was saying that this is the risk of horse riding. You know, people are really passionate about horse riding, actually, but much higher risk of permanent injury and harm. Anyway, people didn't like this. You know, it was an editorial. They didn't really quite like this, but I think it is useful to put things in context. So when we start looking at drugs, most of you are aware, well, people look at illicit drugs like ecstasy and many other drugs, they're kind of quite happy to discount things like alcohol or many of the other major drivers of morbidity and harm in our society. So these are the horses. These horses here, this is a Finnish, like, right, this actually exists, is that there's weird Finnish clubs where they get on hobby horses, and I think that's probably safe. So, we'll talk a little bit about the host, and talk a little bit about the toxicity. So, you know, so we think, well, you know, people who go to festivals are more likely to use drugs or pee. So one of the big features of the host, we're going to come back to this in the environment, but certainly the stuff when you look at the cases that we were seeing, when you look at which the coroner reviewed, but there's also a large number of other cases that we've been reviewing. The issue of people taking multiple doses and indeed panic overdosing. So you're typically thinking they're going to be picked up or seen by the police, and they're, you know, if you've taken 4 or 5 tablets to the party, taking all of those tablets has been an issue. So one of the issues with ecstasy, which has actually been quite difficult to convey in the media, just whenever the media interview us, they seem to neatly cut off the part where you say, well, if you're going to take ecstasy and want to take multiple tablets, you should space them out. But this has been a real feature that if people increase the dose, and this happens with anywhere in toxicity, if you push the dose up, you have an increased risk of harm. Having said that, there'll be lots of people who've double dosed and have had multiple doses who do not end up in a tent, who do not end up in an intensive care unit. But it is certainly a risk factor. Okay, and you obviously got, at a dance party, there may be much higher levels of physical activity than perhaps you might have at a house party. The ambient temperature may also be different. We'll kind of come to that in a second. And the other issue is, do people seek help? And and what are the barriers for that? And again, this dovetails very neatly to start thinking about what environment have we set up. Are we setting up environments that allow people to seek help, that provides accessibility to them, or is this, all, looking a doubtful option for people? So how do people seek help, and indeed, how are they even aware that they may actually have issues? So is there any pharmacogenetic variation, which is being looked at? So by that I mean, is there a genetic difference in the way people handle drugs or the way that the drugs interact with the receptors? And whilst we can say in general there's always genetic variation in the way drugs are handled, there's not a lot of evidence for this in ecstasy, but this is actually something the coroner's asked us to look at. So Matthias Litti is a Swiss colleague of mine, and he's into hypothermia and into Mdma, and just distorted a little bit. So, but I'm just going to take you through this. So, as you're aware, Mdma, like many drugs, is being used and been explored for psychiatric diagnosis. And so they have been doing work looking in particular at post-traumatic stress disorder and the potential role of Mdma. And so what I'm going to go, this is some of their summary data. So this is in a Swiss laboratory, and the temperature is 22 degrees with people sitting down there quietly. And he's reporting on a total of 96 subjects of various studies they've done, and they give pharmaceutical grade Mdma, so about 125 milligrams is the dose that he's reporting here. They've done some lower doses, 75 milligrams, which I'll touch on in a minute. 125 milligrams is kind of an interesting dose. If you look at the average dose in tablets, in C's tablets over the last 8-9 years in Australia, it's around about the 100 milligram mark. That doesn't mean, of course, obviously that means there could be some with more and some less, so it depends on quality of manufacture. But nevertheless, so here's a dose that, it's thought to be a therapeutic dose, or in terms of using this to experiment to see whether it's worthwhile in post-traumatic stress disorder. It's a dose that's kind of comparable at least to a single dose, perhaps, or what on average people might be taking if they only took one sort of tablet. So of these 96 subjects, 24 of them developed a temperature of greater than 38 degrees. So that's just a little bit warm. 3 of them went above 38.5. None of them went higher than that. Okay, but these are normal volunteers sitting quietly. Okay, now this here is kind of averaging. These are the control placebo arm when the people were in placebo, their temperatures, and this is their temperature here, with these error bars kind of going up. And you'll see that the temperature effects were peaking in these normal subjects 2.5 to 3 hours after exposure. The interesting thing about that is Matthias noted that mostly the temperature, the the subjective effects of pulse rate and other things that people detect start to subside in about an hour and a half. So the actual temperature, they kind of, from their own sort of sense of things, they think, okay, pulse is slow, you know, I'm going on. But the temperature is a bit delayed after that in those normal volunteers who had a temperature. So I'm going to come back to it. So there's three basic mechanisms, and it's kind of, you know, this has been looked at in animals and I've kind of worked through. And so the first thing that happens is I'll come to the other diagrams in a second, but the way we control temperature is that normally we have a thermostat, you know, in our brain. It takes some signals centrally from the brain. It also takes some peripheral signals. And when it detects us to be a little bit too hot or too cold, when it's too hot, it tells us to vasodilate and to dissipate heat. When it's too cold, it tells us to shiver. It appears that probably this is affected by both serotonin and dopamine in a wacky sort of way, because it affects it at both ends. So at least in animals, if the room is cold, then the animals actually will tend to develop hypothermia. So it kind of resets the lower end of the thermostat lower, and the animals develop hypothermia. Whereas if the ambient temperature is hotter, then the thermostat sets higher. So basically, it sets itself up so if you're a radiator, it says don't boil over yet. So it doesn't dissipate heat. So it's a slightly odd sort of thing, but we're interested, obviously, in the situation of temperature. So that's the first thing. Then the second thing is that if you have catecholamines, it tends to vasoconstrict you. And as one of the major ways that we dissipate heat is through vasodilation. So it mucks up with heat dissipation, but it also, and I'm going to show you the pictures in a second, the other thing that's really very critical with this is that catecholamines, whether they're drug-induced or indeed even endogenous, they cause the mitochondria, which is normally our little energy factories, they cause them to uncouple from producing energy, and they produce lots of protons and heat. And that, so you've got a situation where it's a bit of a triple whammy. You've kind of mucked up your thermostat, you've clamped down how you dissipate heat, and then you've got some mechanisms where at a cellular level, regardless of whether you're dancing or not, you know, you're sitting, this is what's happening to people sitting down, at a cellular level, you're starting not to produce energy in the normal way, you're just producing heat. And so that drives some heat up, and that's what drives this hypothermia. And then, as I said, you can add other effects into this, the environmental effects. So I'm just going to go through. So I just mentioned here, so this is the hypothalamic control, just sort of saying, okay, so that's important. So we just said that your thermostat is not working quite so well. But probably the major driver is that once you release a lot of catecholamines, you start to get lipolysis and breakdown of some of these cells that are release of free fatty acids. So these free fatty acids, I'll kind of have a simpler diagram, but what these free fatty acids do is they move both into skeletal cells and into brown fat. And this thing called UCP is called uncoupling protein. Uncoupling protein 1, there's actually at least 3 of them. But it's because this occurs both in skeletal muscle and in brown adipose tissue, and this is what starts to generate this sort of temperature. And the reason why this is important is that whilst I've just displayed here, so we've induced this with drugs, but as people get critically ill, and this is where we think that the real slippery slope in drug-induced hypothermia is when people's temperature starts approaching 40 degrees, their own catecholamine levels start increasing as well. So they're probably tipping into a critical illness thing where they're actually kind of going down a bit of a death spiral. If you follow my drift, they've got so sick, they have so much catecholamines that they start to continue this regardless of the background of drugs. And so this is sort of, so this peripheral furnace, you know, while we've got that central control, but this is probably the major problem that we actually have, because this is, as I said, it's initially drug-induced, but there's a point where people get sick enough where it's going to probably be self-perpetuating just because they're critically ill. And so we actually have to do some radical things to cool them all down. And then, as I said, you've got this whole problem that if you vasoconstrict, you're just not going to dissipate heat as well. So these are all host factors. And given that, as I said, this can occur to some extent, in about 20% of people, normal volunteers, in a cooled lab doing nothing. So the complications, as I said, effectively when we start to cook tissues and cause cells to break down, you get multi-organ failure. The hyperkalemia is because of cellular breakdown. When your potassium gets high enough, you're going to have a cardiac arrest, and it's very difficult to resuscitate people from this. And so all of these things, for any of you who have ever worked in any sort of critical care situation, this is just body failure in extreme illness.
So, Andrew, can I ask, is there a natural pausing point for the question? And to the audience, would you like a break or would you like to press on and finish a bit earlier? Paul Haber's been preferring the press on.
Is he on? All right. Okay, so I want to talk about environment. And so, well, perhaps before we could get there. So needless to say, I work both here, but I work for the Poison Centre. And the Poison Centre in New South Wales, there are a number of tertiary toxicology units in Sydney, and all the toxicologists in New South Wales also work for the Poison Centre. And as it turned out in these, for many of these early presentations in the 2018-19 music festivals were actually coming into hospitals such as Nepean and Westmead, where in fact they will see people that I actually employ with another hat on. And this was kind of useful because New South Wales Health, for a variety of reasons, have got a little bit more engaged with us about other events and our ability to pick up things. But it also meant that that we were actually in quite a good position to start to try and work out systematically some of the issues that were going on. And so a fair bit of our time has been working out what were the factors that drove some of this. So environmental factors, okay, in particular, obviously we're dancing, et cetera, you don't go there to stand still. But the ambient temperature, I've already pointed out, is clearly very important, but the infrastructure is also very important. And by infrastructure, I mean a wide raft of things, everything down from how many toilets you have. You see, because if you don't have enough toilets, then you don't bother, you may not drink enough fluids. You also need to have fluids because you don't want to pee. You might just want to think you're a camel or something. So, so how many toilets do you have? How much fluids are there places for people to chill out and to kind of cool down? If there are medical services, how easily accessible are they? So in some of the festivals we had, for example, outside of Gosford, there was actually quite a long distance to the medical tent. Then where is the festival in relation to external services, and how do you get to and from there? So, for example, if you're looking at this festival here, is a single sort of road. If you have to move all of your vehicles in and out of that, and if it turns out that, using the Gosford example, that Gosford Hospital is 40 minutes away and you may not have an ambulance there, all of these sort of infrastructure logistics are actually quite important in terms of both increasing people's risk and also then managing their risk if they have medical complications. So this is, looking at, so we went through analysis and it perhaps wasn't appreciated. So most of this analysis was all done within a day of all of the deaths. So we had actually had blood levels of ecstasy and actually had record notes. So most of the things that the coroner subsequently had determined were all, weren't particularly rocket science, or actually quite easy to work out. But the bottom line is, for a start, the ambient temperature was, last season was hotter, than the mean maximum temperature of the previous month. And that doesn't mean, of course, that there weren't hot days before, but it did appear that there was this high ambient temperature, which is going to increase risk. It's not a Swiss laboratory. The second thing is that there were some substantial things in the environment, and this is very kind of clear in the coronial report. This was clear in our interviews of survivors, that the police presence was not actually helpful at all. Now, as you're aware that presumably he's had I've got a working with children check. I'm not sure if David Elliott has, but so the notion of we've lost the dogs and things here, but the notion of, of being strip searched, of multiple police, of dogs, etc., very clearly actually changed the way the environment is. And this would be, for example, this would be an obvious difference between, for example, a private party, down the road in someone's house versus these sort of open public events. So this very much kind of changed the environment, and this interacted, as far as we can see from reports, with the host behaviour, that is about what people did in terms of dosing themselves. And so this is a really significant issue. So, there are sort of these sort of issues. So if you want to think about pathogens, I'm going to come and show you some of the analysis, but if we're just thinking about ecstasy, well, we want to know, what's the purity? Were there any other contaminants that might be players that may have increased toxicity? What was the dose? As I said, we may actually have significant variation in dose. Were there any other concurrent substances, not necessarily in those tablets, that people were taking? So alcohol is relatively common, but other drugs. And if so, is that establishing things? Other things that relate to the host. So whilst we're looking at genetic things, there are other variations. So even having intercurrent infections and things like this may change your risk. The dosing behaviour is very, very important. And then what's your level of activity and how early do you seek help? And if we're going to offer help, we have to go to the environment. As I said, I've talked about ambient temperature and infrastructure, but when you're seeking help, how well equipped is that help to actually recognise what's going on and to actually mount a good response? And so there's been a lot of variation, I guess, in that sort of space as well. So this is so 40 cases. So not all of these are just from the last season, kind of coming up just up from end of September to Australia Day. So these are 40 cases that came into hospital, and you will see that there were the five deaths, a large number of people intubated, often in the field. So the part of New South Wales Health response was to try and get more integrated medical teams into larger higher risk festivals, and to try and organise retrievals. So a number of these were very critically ill, but were probably very aggressively treated. So lots admitted to intensive care. So this is the sort of cohort we've got. So these were, these were sick patients basically. So one of the things, even back on the festival there, they've become more formalised at the moment. There was actually quite rapid turnaround. So fast the forensic laboratories were running those samples where they kind of got them, and so generally we knew what was what people had taken, certainly by the next morning. And so this is the number. This is in all these 40 patients. So 35 of these people had MDMA. There was some cannabis. There was some methamphetamine or amphetamine, some cocaine, some benzos, some GHB. Some people obviously more than one drug. But if you look at the really unwell patients, then you kind of look at, so we have, of the 40, 35 have ecstasy detected. Of those with ecstasy detected, 73% had toxic levels. This is a rather rubbery sort of number that forensics report, but what they're talking about are levels that are much higher than seen in therapeutic doses. And then but 22 had taken other recreational substances, and also there's alcohol. So when you looked at the other recreational substances, by and large, they didn't seem to actually explain the syndromes. But this is not surprising. This is what you'd expect at a party, that people are going to take more than one thing. So in these ones, the people who thought they'd taken ecstasy, indeed, it largely did appear that they actually had taken ecstasy, because that was the season. But this is just looking at various co-ingestions. So if these are ecstasies down here, these are the number of other drugs that, for example, using this as an example, here is someone who's got some THC, some benzos, etc. So people were taking other drugs, but this is the stuff to pick up. So one of the things that New South Wales, or the FAS have done is they've actually upskilled and increased their analytical capacity to try and look at not just the festivals, but also to do better surveillance year round. Okay. So one of the big issues then, and you know, it's one of the things that was kind of driving me a bit nuts, because I think the way that the politicians dealt with pill testing kind of, in my view, really distracted from a lot of the other issues. So I think pill testing is a very important message about harm reduction and about telling people that you care and engaging. It's a completely opposite message, perhaps, to putting a lot of police there. From depending what you do with pill testing, I mean, from a pharmacology point of view, the ideal thing would be a detailed analysis, of the pill, telling me the strength and any other adulterants. Much of the pill testing, just because of economics, it has been about saying, yes, this is ecstasy, or no, this is not ecstasy, for example, if you look at those sorts of studies. So from a toxicological point of view, that probably makes very little difference to us in terms of our acute management. From a public health point of view, knowing what people are taking, be it through pill testing at festivals or indeed by systematically assaying patients that we're seeing all the time, is actually quite important. Because the reality is, if this is a Swiss lab making ecstasy, this is there's a range of production facilities. So, but I thought it was very interesting. What tended to seem to happen to me in the narrative, which did change a little bit in January, was that the newspapers, who never actually seem to say anything you actually tell them, but they would say someone has died of an unknown pill, and then people not unreasonably said, I think that if it's unknown, surely we should know what it is. We should have pill testing. To which the government then rather unhelpfully kind of, I think, kind of jumped on the pill testing wagon, which I can kind of get what Gladys was on about. She could have probably dealt with this in a different way and not distracted everyone. You would have probably seen, if you look at the media reports eventually, we did actually say, I said, for God's sake, we are assaying people. We know that they've got high levels of ecstasy and things. We need to actually say that we at least know that this is ecstasy, that this is not necessarily just the idea that it is something else, that people weren't expecting. At the same time, trying to get the politicians to understand that one tablet, is highly unlikely to kill you, and ecstasy is actually a very low-risk recreational drug, at least, taken that sort of way. It's just not something that anyone really wants to hear. So this is a somewhat older paper, but just kind of going, as we were saying before, you can get a variation in the amount of the amount of ecstasy in tablets. As I said, it looks like it's been more consistent in Australia, but clearly for an individual there can be a significant variation. And then how people consume pills. So I think I got interviewed a number of times in January, because I think the Ministry of Health felt somewhat constrained by the political position, and every time I would say something about how to dose yourself with multiple ecstasy tablets, that never made it through to the paper. So it was all, it really is sort of one of these sort of, Alex has probably got a lot more experience in this, but basically it's a very unsatisfying way of communicating any sort of risk, because effectively, depending on whatever the political leanings of the paper is, the message is sound-bited down to sort of something that's not terribly helpful. So what we had identified really at that stage about things we could do is, in particular, we felt the medical response needed to be sorted all out. And I think David Collins got briefly upset with me on Twitter, saying that I was against pill testing. I said, no, David, I didn't say that. I said that I didn't think pill testing was going to help acutely. And it was a slightly different sort of message. I still don't think it's going to help us greatly acutely, but I still think it's an important thing to do for other reasons. So one of the things that New South Wales Health has done, apart from try and look about what standards, what constitutes a medical team, and for a high-risk festival, what's the retrieval look like, and all those sorts of things. So an extensive amount of work was done by my colleagues about doing all of this. But one of the things that they have done is what we call in the PRIZE project, which is being run through New South Wales Public Health and the Poison Centre and FAS. And effectively, what we're doing is they're rolling this out to all the emergency departments and intensive care units in New South Wales public hospitals to pick up any patients who are coming in with unusual drug symptoms, to take them and to look to analyse, so we can kind of get a blueprint about what people are taking and start to get in a little bit of that. So, for example, if we're finding new amphetamine analogues in the marketplace, we don't really want to find out necessarily about that, particularly at a festival. If we're actually already aware that we're getting those cases in, then we need to start doing that messaging a little bit more upfront. So this is looks to be an ongoing sort of process where they've bought extra equipment, they've hired extra staff, and so it's the prescription, recreational, illicit substance evaluation. So it's not just recreational drugs, it's anything that we think is aberrant. So this would include, for example, currently we're looking at fentanyl analogues and the other things coming into the market, but also drugs that are being, prescription drugs that have been diverted and turned up. So anything that the gatekeepers, who turn out to be us, think that's interesting, eventually we're going to be able to do. At the moment, in the pilot sort of stuff, which is just being run in Westmead and then rolling out to Mount Druitt, Blacktown, and then Nepean, but then we're going to roll out to other hospitals, is about just to pick up, is to sort out all the mechanisms of how we collect samples and move things through. But it will be rolled out this year to virtually all the hospitals. So, and then part of all of that, in addition to sort of picking up things, is also to actually to try and evaluate any episode. So the recent deaths that occurred in the last weekend, whilst we may be looking to determine what drugs are taken, but to continue to kind of go back and to make certain, are there other things in the system that can be altered to change outcomes. So, as I said, since after the 5 deaths, in the high risk festivals where they put in medical teams, there were actually no subsequent deaths in those ones, despite lots of ill people being there. But there was a lot of other work done. There was a lot of other work with DanceWise and many other sorts of groups. And currently at the moment, a lot of the discussion is literally around, we've had big discussion with DanceWise about, well, what do we, what's the safe amount of ecstasy to take? And so these are the conversations that the public health in New South Wales are actually really looking at to try and kind of get out there, because clearly it's pretty naive to think that people are not going to go and not take things. As I was pointing out this morning, I said if you gave 10,000 kids a bottle of vodka and went to there, I almost certainly you'd probably have more worse outcomes. So this program is about looking at us to notify, to clinically test, to coordinate response, and to set up feedback loops so we can feed back to the medical community about both what we're seeing, and we envisage we're almost going to be doing that in a live sort of way, what we're seeing, but also what the implications might be for clinicians. So, for example, what does NBOMs look like versus just MDMA? Are there differences in management that you need to do? So we're trying to look to pick those things up. So I think it takes a lot of time. There was this is a New South Wales Health Award, which seems a bit circular, that they congratulate themselves, but I'm sitting down there. There's Kavita, who is an ED consultant at Westmead, who was intubating people. Actually went to see what things were like and found herself intubating people, and so a large number of people have been involved in policy response, in medical response, and moving through and trying to. And this is an ongoing development, but kind of iteratively trying to go through and to work out how to make festivals safer, how to kind of shift, and I think this is going to be a real challenge, how to try to shift the government into some sort of harm minimisation sort of approach when they clearly got another political agenda. There's other work due. We've got recently we've got a grant to looking at just doing transdermal monitoring, with those funny little stickers and things, to see whether or not we can get people to present earlier, and whether we can introduce harm minimisation messages at the time of doing those things. So there's a lot of activity, around all of this. As I said, it really does reflect, I think, that these are slightly higher risk environments. A large reason why I think they're higher risk, apart from ambient temperature, has actually been the political response, that it's actually just been inappropriate, and clearly it's not really altering in any substantive way, what people are actually taking in festivals. And and certainly for a minority, it's probably tipping and changing the behaviour for them to take drugs in a different way. So we're expecting continued work throughout all of this, the next few months, to continue to refine all of this. But it has been a major challenge to try and work out how to, or to work around government. This is not the health department, but for the health department to work around government to get any sort of appropriate sort of messages out. And really, I think government would just be better if they just shut up and got out of this a little bit, because I think they keep doubling down on really stupid positions. So that's where I'm at.
Stay put, Andrew. Any questions from anybody in the audience?
Yes.
I just wanted to ask, what from a practical perspective, say if pill testing does come into effect, would you have like having like a campaign, go to school, explain what it is to make it
Repeat the question.
Oh, so you're asking, if pill testing comes in, you're asking, I think, two questions. Would we have a campaign in schools about what pill testing is? I think, look, if pill testing came in, there would obviously there's been a whole lot in the media, so already. But if pill testing came in, there would need to be education for users, and there's a whole lot of issues of how people can approach that with not feeling that they're putting themselves at risk. It's a very good opportunity to provide other advice and intervention and engage people. But the net number of people turning up for pill testing, even where it's been allowed, is actually a relatively small percentage. So I was going to go back to before. I still think it's a very important signal about how you're doing business in terms of all of this. If part of the business is like, look, we're here, we're prepared to test your pills, or we're here, we think hypothermia can occur without taking drugs, and we perhaps should normalise that, or that we actually kind of care, we're actually looking to have an environment where people feel safe to present early and things. That's very, very important. So I think I think it's a component of things that we can do. It's going to require education, but as I said, I think it's going to be very difficult to pull off. I don't think they can run the current sort of restrictive policing sort of presence in parallel very effectively, and I think they've just got to figure out some way to. They should have read The Art of War, because I don't really think they've allowed themselves a really easy way to retreat gracefully out of this. They keep doubling down on all of this, and it's just not going to be very useful for us. I think it's going to take a long time. Alex, you're in this space, of talking to regional governments. What do you think? Yeah.
You need to speak into that microphone there, Alex.
Well, I agree with your comments, and they're very, very valuable. Look, first thing to say is that just as Richard said before, that the different drug markets are connected. We argued 10 years ago that different drug markets are connected with one another. The different drug policies are also connected with one another on different issues. And resistance on one harm reduction issue is often connected to intense resistance to harm reduction on other drug issues. So every win we have for one harm reduction policy is a win potentially for advances in other harm reduction policies. So although 5 deaths in the scheme of things mightn't be all that huge, it's of course huge for their families and loved ones and friends. But it's also huge because it means that we can advance with harm reduction in other areas, and that's really critical. We've lost the impetus we had 20 years ago with harm reduction, and these days we've had this kind of intense, dogged intransigence that we're now seeing with pill testing. We're seeing this these days with across the board with harm reduction. You can only aim primarily to reduce drug use, or you can aim primarily to reduce the harm that drugs cause. You can't do both at the same time. You can have zero tolerance for drug use, or you can have zero tolerance for drug deaths. And unfortunately, at the moment, we're back to zero tolerance for drug use. So all the money is being poured into the saturation policing, the strip searching, the sniffer dogs, and the evidence that they achieve anything is less than negligible. We know that they're from several sources, including the 2006 Ombudsman's report, that they're highly inaccurate, that they're expensive, and that they have severe counterproductive effects. With pill testing, it's much harder to evaluate, and an important concept to get across in talking about pill testing is that there are different kinds of harm reduction public health interventions, and they're very different in their evaluation from harm reduction clinical interventions. So with harm reduction clinical interventions, say giving methadone or buprenorphine to a group of people who are using street heroin, we can do trials which show to a very high degree of certainty that there are substantial benefits, health, social and economic, that the adverse effects are low and acceptable, and that it's highly cost effective. That's easy to show with high degrees of certainty. But once you start doing environmental interventions, and this is really an environmental intervention rather than a clinical intervention, the certainty is much less. It's probabilistic, balance of probabilities, rather than beyond all reasonable doubt, as we have with clinical interventions. So it's very hard to talk about all of this in the media, and you're right, the discussion goes through the media, and inevitably that's from a scientist, researcher, medico kind of perspective, that's always unsatisfactory, but it's that or nothing. That's how you get the message across.
So another question, Andrew. You talked about multiple use, multiple drug substances, and patterns of that. Is there a simple instruction you can give to people about combinations that they really particularly should avoid? For instance, is it simple as to say, look, have ecstasy if you want to, but don't drink with it? Where are we at there in terms of giving messages?
Don't drink alcohol.
Don't drink alcohol.
Well, I think that's it's certainly a better message than saying don't take anything, but have a good time. Look, in actual fact, the drug interaction between ecstasy and most other drugs are not terribly important. You know, depending, but again, it all comes down to the dose. So if you look, one of the individuals who actually got quite sick, who did probably only have one ecstasy tablet, and that's what he said in the bottom, but did drink like a large bottle of vodka. Well, in actual fact, whilst they all could have came and said, oh, here's an ecstasy admission because you've taken ecstasy, but the toxicologists that they were going, this is an alcohol poisoning. This is, so one of the things that's happened with all of this, we get deaths all the time, frequently enough in various EDs from people taking recreational drugs and including ecstasy. That you know, what we've actually got, because of the music festival focus, and because it's so politicised, it's all very picked up. You might get a little byline saying, you know, some poor young girl's tragically died having taken GHB or done something, and that's. But this is all charged up in the music festivals and politics, so that it's a media circus. You know, Alex is right. I mean, these deaths are really regrettable, but you know what it's actually sort of done. You know, it may be because of the media circus. It's actually frozen us politically. You know, in a way, if this was just, you know, my child, your child, you know, dying in isolated sort of parties and not all evoked with who's licensing the festivals, who's doing this, all these other bits and pieces. You might be able to move things along. But as I said, we've got politicians who, as I said, they've effectively keep doubling down, not allowing themselves, you know, any way to. I kind of vaguely get, I think, what Gladys was trying to do. And I could think she just needed to get better advice. She could have probably said something like that, given herself an escape clause, not made such a big thing of it, and let it all die down. But in actual fact, she said, no way will we ever do pill testing. And then that generated a whole lot of debate, which I think distracted things. But in actual fact, she could have probably dealt with this another way, left the door open for her to have a trial of pill testing. But I just think it's just really crap advice. And I say that because they gave me a newspaper, Ministry of Health released a draft one, which they sent to me, where they said, we thought we should show you this, said someone from the other ministry, because they'd taken the various sound bites and clips that I had said, or, you know, previously, and strung that together, changing the words, twisting it into some bizarre thing that looked. I thought, fuck! I said, if they put that up, then the media's going to come and I'm going to say, no, that's all just crap. That's not what I said. But this is, and I said, where did that come from? Was that from the back end of the politician's office? Well, I mean, you know, I think I did actually say. I said that someone's going to look at that and then come and want to interview me, and I'm going to say, well, that's all wrong. That's not what I said.